Okay. First of all, I'd like to thank our WHO team for organizing this event and Dr. Jojo Su and Dr. Cho Wen-Xuan for the slide. She spent a lot of time attending and listening to what audience wants and decided on what we should be presenting as a rheumatologist. And also, I'd like to thank all the attendees, all the CRCMR, for your time, energy, and willingness to, learn. And basically, it's like I'm not an expert, but I will share some knowledge I know and try to answer the question you may have based on my ability. And if I don't have an answer, I will get back to you tomorrow after finding out that, answer for you. Okay. So a little bit of introductions for myself. Tomorrow 85, 95, I'm one graduate. The Dr. Taylin who netadane po no tomorrow. Residency at Abington Memorial Hospital, Philadelphia, for 3 years. Then I did rheumatology fellowship in University of Virginia, Charlottesville, and been practicing rheumatology at the biggest HMO organization called Kaiser Permanente in Northern California. This month is my 15 years anniversary working as a rheumatologist, basically the outpatient and some hospital consults. And I became the chief of rheumatology department 4 years ago. So this is a little bit about me. Just introduction. So rheumatologists and COVID-19, we don't treat COVID-19 patients and as a outpatient rheumatologist. However, I think we are affected by the COVID-19 as a small subspecialist, because you all know that there is a big thing going on in the at the start of the COVID-19. Plaquenil could be affected by or in the treatment of COVID-19. So we face that shortage in Plaquenil. Then our patients are on immunosuppressants, and so the question came whether we should hold the medicine in the pandemic or not, and come along if they are high risk. If they are high risk, then they go to work together with working with the other people in that COVID-19 pandemic. So we have to give them the letter saying they are high risk to get the COVID-19, and they have to sort it out. They can work from home because there was a lockdown at the beginning, and etc. Then vaccine developed, and whether they are safe to do the vaccination is another question. Recently, we have a shortage in sulfasalazine, not directly related to the COVID-19. Some of the company dropped their production, maybe, I don't know, shortage of the raw material or not. And then we face the joint symptoms flare up during the COVID-19 infection. Some of our patients got COVID-19 infection, some pass away, some survive. And patient who doesn't have autoimmune condition develop long haul symptoms after COVID-19 symptoms, and they were referred to the rheumatology department because they have joint pain, joint swelling, stiffness, and etc. When the serologies were checked, we also found out that they have rheumatoid factor ENA positive because of the non-specific immune stimulation. And some patients develop flare-up of their joint symptoms after the COVID-19 vaccine. And recently, the question is whether they should get the third dose of vaccine because they are immunocompromised and they can produce antibody like general population. And the last, and currently we are facing the shortage of the Actemra or tocilizumab because the production is the same. However, no, we are now sharing with the patients who have COVID-19 cytokine storms. So pretty much rheumatologists are really busy, and it's like an indirect way we were affected by that COVID-19 infection. So even though we're not treating like infectious disease or pulmonologists or hospitalists, rheumatologists are, impacted by that COVID-19 one way or the other. I was told to start out with the case, so I'm going to present the case, and we go from there. We have 63 years old man with a history of Hep C, treated with the antiviral. He also was diagnosed as leukoclastic vasculitis in 2013, pulmonary embolism, deep vein thrombosis on the blood thinner, enoxaspirin. He was doing well until a month ago. He noticed that difficulty in breathing and admitted because of the severe shortness of breath. He also complained about joint pain, arthralgia, with the stiffness in the morning, with the occasional swelling in the joint. He reported that he has a joint swelling and rash, subjective fever, and chills at home. He was he quit smoking in 2015. This is a rash on the examinations in his lower extremities. Here are the labs. You can see that kidney function's getting worse, white counts going up, the anemia getting worse, platelet counts elevated compared to the baseline, and inflammatory tests, SERRATE and CRP is elevated. X-rays of his feet and ankles are normal without erosions, deformities, joint effusions. Chest X-ray, you can see that difference in that, first chest X-ray and second chest X-ray. Apparently, you can see more infiltrate on that, changes in that second chest X-ray. Clinically, he get worse with the hemoptysis, low oxygens and requiring more and more oxygen. His kidney function get worse, anemia getting worse, and rheumatoid factor is elevated at 700. However, COVID-19 test came back negative. What will be your next step if you were seeing these patients? So we have 63 years old man with a palpable purpura, joint swelling, acute kidney failure with that abnormal RBCs in the urine, anemia, hypoxia, hemoptysis, COVID test negative. Would you do anchor, ANA test, bronchoscopy, and alveolar hemorrhage, CT chest and monitor, or repeat COVID with the PCR test? So basically, he ended up with that bronchoscopy, and which showed the diffuse alveolar hemorrhage. He also had a kidney biopsy. He was found to have a low complement, high rheumatoid factor, and high positive cryoglobulin. Anchor tests were negative. So his final diagnosis is hepatitis C associated with cryoglobulin-anemic vasculitis, which with that diffuse alveolar hemorrhage and rapidly progressive acute glomerulonephritis. So basically he has like hepatorenal, pulmonary renal syndrome and vasculitis rash. He got plasma exchange, IV steroid, the high dose steroids or loading dose or pulse steroid, 1 gram for 3 days, followed by the prednisone, 1 milligram per kg a day. And he eventually got rituximab, 1 gram 2 doses in day 1 and day 15. Rituximab is a B-cell depletion CD20 inhibitor. We will talk more about it later in the presentations. Epidemiology of cryoglobulinemia. Mainly, most of them are asymptomatic. You don't even know they have cryoglobulinemia. Mainly in the people who have hepatitis C, 65%, majority of them, and then also HIV and Hep C combination patients. It's 64%. And some of the rheumatological condition, about 25% of them can present with the, can have a cryoglobulinemia. It is a small to medium vessel vasculitis. When do you suspect? You will suspect if patients have rashes, palpable purpura, skin ulceration, joint pain, joint inflammations, peripheral neuropathy. Sometimes they can present as a foot drop or numbness and tingling in his in their feet or the extremities, and microscopic hematuria, proteinuria, and elevated rheumatoid factor, low complements level. If patients has history of hepatitis, either B or C, or HIV, or autoimmune condition like lupus, Sjogren's, or rheumatoid arthritis, or multiple myeloma or lymphoma, oncology patients, you have to suspect if they present with that, skin rash and all those symptoms. Another similar presentation, differential diagnosis of skin rashes, joint pains, inflammation tests are elevated, so will be the macrophage activation syndrome for the rheumatology patients, and then also known as the hemophagocytic lymphohistiocytosis, HLH. It can be two forms, like the genetic or like secondary to the autoimmune condition, or infections or malignancy. It is kind of like a cytokine storm in a way that, because there's no check and balance in that the natural killer cells and cytotoxic T cell. So, it's like an imbalance in that regulating system, causing the macrophage activations and overwhelmingly productions of cytokine, causing the inflammation, causing the end organ damage. So here, so the hallmark is that you can see that hemophagocytosis, the cells, it's like you can find inside the macrophages, you can find RBC, WBC, platelets. Basically, macrophages are going crazy and eating up all those cells. This is the bone marrow biopsy. This is a clinical feature comparison between systemic juvenile rheumatoid arthritis, macrophage activation syndrome, and HLH. You can see that D dimers are elevated. They have rashes. They have arthritis. They have fever. White counts elevated, and most of the time, but MAS and HLAs, the WBC drop, and ferritin's elevated. So it's like some of the features can be found in people with the COVID-19. So in the pandemic, common things are common. The presentation with the shortness of breath, rashes, could be COVID-19 in a way, but we don't want to miss that life-threatening rheumatological conditions such as vasculitis, macrophage activation syndromes. So that's the reason we like to present the cases which can mimic that COVID-19. Any questions so far, or should we continue? Okay. So so that's like a macrophage activating syndrome is a kind of like cytokine storm in the COVID. Like I said, I'm not expert in COVID-19 or cytokine storm. How, in this era of the COVID-19, when you talk about cytokine storm, we are like six blinds in that, with the elephant. No one knows exactly what is going on at this point, but more and more data are coming out, and hopefully we'll find something that we can help people who are really sick with the COVID-19. So, I like to touch like briefly about the basic immune system, but I don't want to spend too much time on it. And then, but there are so many slides about basic, going back to basic immune system. Our immune system is expect to recognize foreign invader. So basically like infection or pathogens like bacteria and virus. And so that, it's like we can produce cytokines to, get rid of the infections, and then make a balance, check and balance. If you produce overproducing cytokines, you will be in trouble. But if you don't produce enough cytokines or attack the virus, then you will have a sepsis, and that's, it's like that's not going to be good for that, a body. If we produce a lot of cytokines, then we will, it will cause a significant collateral damage, like cytokine syndrome in COVID-19 infections. And we will touch base on the inflammatory response, but I would like to focus on that monoclonal antibody which is a hot topic, and then COVID-19 vaccination in our immunocompromised patients as a rheumatologist. As we all know that pathogens, antibody, it's antigen, what is innate immunity, and adapted immune response. So I don't want to go into detail about the basic immunology. However, those are the things our body has it to have a defense mechanism for the invaders. This is the immune system and cells of the immune system, starting from the tonsil, your skin, thymus, spleen, to the lymph nodes. And we produce a macrophage and dendritic cell from the myeloid series. And from the lymphoid series, we get like natural killer cell and lymphocyte, T lymphocyte, B lymphocyte, and which produce a plasma cell. This is another diagram showing those cells. And tolerance is important because you don't want to be too sensitive to all the stimuli you face in life. However, you have to know, your body immune system has to know self from the non-self. If you cannot differentiate, that's where the autoimmune disease happen. So T cells, killer T cell destroy the infected cell. Helper T cells is supposed to coordinate the attack, and regulated, T cells make it check and balance, making sure everything is in balance. So this is how humoral immunity involved from the B cell. They produce that memory B cell, so that next time you encounter with another the same antigens or the virus or bacteria, your body can act on it. So when your immune system responds to the infections, usually you generate integrated immune response. And then eventually the goal is to resolve the inflammations in your body. Your immune system is supposed to detect infections and contain and eliminate the infections, and develop the memory so that next time when you encounter with the same pathogens or antigens, you will get the stronger response on that, and then faster response because of that. So antigen can be self-antigens, viral antigens, and then there's antigens and receptor will work like a lock and key mechanism. So this is how, like when you get that skin cut, then your body, your immune system bring the macrophages, activate that macrophages, and then complement activation occurs, and T cells and B cell working together to produce that adaptive immunity and get rid of the infections. So cytokines are very important. They are small proteins that communicate with the immune cell. They are autocrine, it works in the same cells, and paracrines, adjacent cell, they can act on the adjacent cells, and endocrine, it goes through the bloodstream and it can work as a long distance. Chemokines are like function as a recruitment of the WBC and trafficking, and its dysregulation of the chemokine may lead to the hyperinflammations. IL-10 and IL-1 are IL-1 receptors are like regulatory cytokines. Complements are like it's like complements work together with the activates the antibody. So cytokine storm, not only the macrophages activation syndrome or HLH, we have seen it iatrogenic, like cancer treatment, like chimeric antigens or receptor T cells, and immune checkpoint inhibitors. Rituximab treatment can cause that cytokine storm. And also CABG, the carrier bypass surgery, stem cell transplants. Sometimes patients can have like fevers and all those symptoms. The first thing we think about is the infection. However, infection workup is negative. Turn out they have cytokine storm. It can be from the infections, sepsis association, or monogenic, kind of like an autoimmune polyendocrinopathy syndrome. And right now, hot topic is COVID-19 associated cytokine storm. As you all know, in COVID-19 associated cytokine storm, we see a lot of cytokines, activated immune cells, elevated C-reactive protein, D-dimer, low albumin, low lymphocyte, kidney functions abnormalities, and thrombosis. There are so many theories. Actually, no one knows what trigger it and how to treat at this point. as a rheumatologist, I don't know exactly how all those, it's like the COVID-19 cytokine storms works or treat. However, if you look at this diagram, here there are a lot of cytokines, like IL-6, IL-1, TNF alpha, Janus kinase inhibitor. Those cytokines are very familiar and known in the known factors in the pathogenesis of the rheumatoid arthritis. So we have used TNF alpha blocker, IL-1 inhibitor, JAK kinase, Janus kinase inhibitors in treatment of rheumatoid arthritis. So in this slide, this is the pathogenesis of rheumatoid arthritis. Antigen presenting cells will activate the T cells. And then T cells will activate the B cells. And so CD helper cells secrete the cytokines IL-17 and interferon gamma, and then they recruit that macrophages. Then, macrophages produce TNF, IL-1, IL-6, and those the cytokines causes the joint lining, synovial cells to proliferate. And then in the joint, the antibody like rheumatoid factor, CCP antibody form the immune complex and activate the complement system, causing the joint inflammation. Not only the joint inflammation, it can also cause, IL-6 can cause a fever. And also in the liver, the cytokines produce hepcidin, which reduce our iron binding and causes anemia or chronic disease. In the lung, fibroblasts activated by the cytokines causes that scar tissue and then, interstitial lung disease. Skin nodules is made of macrophages and lymphocytes. So if you look it up those cytokines, we have known for the pathogenesis of rheumatoid arthritis. It can be also found in the people with the cytokine storm in COVID-19 infection. What do we know as a rheumatologist is we know how to use a medicine to block those cytokines, like tocilizumab, sarilumab, sirukumab, the IL-6 blocker. Having said that, though, I have only used tocilizumab for the patients with the rheumatoid arthritis and giant cell arthritis. I have not used the other two so far. And we also have the TNF blocker like Remicade, infliximab, Enbrel, Humira, Cimzia, etc. IL-1 inhibitor anakinra is used in that juvenile rheumatoid arthritis, and then macrophage activation syndrome. IL-17, IL-12, and 23, those are medicine blockers are used for the psoriatic arthritis. Beta cell block that T cell activation, so it prevents all those cascade of inflammatory process. So that is the reason, more and more medicines are used for that, COVID-19 infections, patients who are hospitalized and sick with that cytokine storm. And another topic is what is monoclonal antibody? So they are genetically engineered protein derived from human genes that inhibit some specific component of the immune system, and it will modulate the immune response. So this is the picture. You can see that there's a variable region in orange and constant region in that blue. There are several types. There are 100% mouse, or chimeric, meaning hybrid, human and 25% of mouse. And humanized is 100%. Humanized is 90% human and 10% mouse, and human is 100% human monoclonal antibody. So this is a different kind of TNF blocker. You can see that the infliximab is chimeric. Green is a mouse, and then orange is a yellow. Orange is a human, and this Cimzia, certolizumab, is it's like very big molecules, and we can use this medicine in pregnant women who have rheumatoid arthritis, ulcerative colitis, because it does not cross that placenta. So it is safe for the baby. Because it is pegylated with the polyethylene glycol. It's a huge molecule. Adalimumab, Humira, and golimumab, the Cimzia, are the human recombinant antibody, monoclonal antibody. It is interesting that based on that, if you look at the name, then you can tell what type of biologic they are. If it is N with the sept, like an etanercept Enbrel, it is a receptor blocker. If it is N with the Cimab, it's a chimeric medicine, monoclonal antibody, like infliximab and the rituximab. If it is N with the Zumab, it is a humanized, like the Cimzia or IL-6 inhibitor tocilizumab. It's a humanized monoclonal antibody. If it is N with the TNAP, it is an inhibitor like tofacitinib. I always call Xeljanz because it's easiest to pronounce. And if it is N with the RA, it is a receptor antagonist. It's anakinra. Anakinra is like IL-1 inhibitor. Belimumab is a medicine, Benlysta. We use it for the lupus. It is now started to use for the lupus nephritis. So we all know that interleukin-6, IL-6 inhibitor plays a role in the inflammatory process by activations of the several cells in the immune response. They have 2 chains, and then it's make a IL-6, IL-6 receptor complex, causing activation of the Janus kinase protein and activation of STATs and SHB2 protein and gene causes a gene expression. What does the Actemra or tocilizumab done is it prevent the formation of that complex, so that prevent that inflammatory cascade. Like I said, it is recombinant humanized monoclonal antibody. It can bind to the membrane bound or soluble form of IL-6 receptor. It is approved in rheumatoid arthritis or giant cell arthritis and juvenile inflammatory arthritis, and also approved for the oncology cytokine release syndrome due to the chimeric antigen receptor T cells activation. So dosage we use are different. It is 162 milligram per week or every 2 weeks. It coming with the either prefilled syringes or the pen, like an EpiPen type. So I started out with the every 2 weeks because you can always increase the dosage if needed. sub-Q injection can be done, self-injections as an outpatient setting or patient at home. And infusion, IV infusion is every 4 weeks. The dosage are 4 milligram per kg, or you can up it to 8 milligram per kilogram if it's not, if the response is not where you want to be. I don't know that what is the dose they use for that in the COVID-19 cytokine storm. All I know is they use a higher dose, and it's not every 4 weeks. So we have used in the different dosage and then different form. I don't think it is approved. Sub-Q injections are approved for the inpatient COVID-19 patient. It's only the infusion. What are the side effects is like liver enzyme elevation, demyelination disorder, high cholesterol. And we are very careful and avoid the Actemra if patient has a history of GI diverticulitis or the perforation history. What do we do for the monitoring? We monitor liver enzyme, both AST and ALT, cholesterol level, total cholesterol, including HDL, LDL, and a patient has to have a negative TB skin test. We all, my TB test is positive. We argue that because we have, the vaccine for the vaccination as such try. It doesn't matter when you need to take those medicine, you have to have a negative TB skin test. If your TB skin test is positive, we treat them with the isoniazid for the 9 months to prevent the reactivations of tuberculosis. We do not initiate if the absolute neutrophil count is less than 2,000. Platelet counts are low, or ALT and AST levels are elevated more than 1.5 times upper limit or normal. Where I work at our institution, we have, when you put the orders in for the infusion center to infuse Actemra, we put all those parameters as a order set, so that nurses can take a look at it, and when there's an abnormal blood test, they communicate with the doctors, us, and we decide whether we should hold the medicine or we will continue giving the medicine based on that patient's clinical symptoms and patient condition. We recommend not to use in pregnancy, and we recommend people who are on Actemra not to breastfeed, because there's not much data on those. So that's like the IL-6 is produced from the monocytes and macrophages. Then on the liver, IL-6 can cause acute phase reactant. C-reactive proteins will be elevated, ferritin level will be elevated. It's also called leukocyte migration, proliferation of synovium, and release of the MMP. It's also it works on the osteoclasts and causes the bony erosions or the bone loss, and it increases the vascular endothelial growth factor, causes the angiogenesis, the increase the permeability of the synovial lining. This is the approval history of tocilizumab. Since 2010, it is approved to use for the moderate to severely active rheumatoid arthritis. It is not the first line treatment. We usually use oral disease modifying agents such as like methotrexate, leflunomide, sulfasalazine, Plaquenil, etc. Then, it's like if not improvement, then we move on to the biologic. And 2017, we got approval to treat giant cell arthritis for subcutaneous injections. However, some of our patients who have Medicare, the different type of insurance, the subcu injections are not covered, so we end up giving them intravenous infusion. 2017, it was approved for the cytokine release syndrome. And in March of 2011, it was approved to treat interstitial lung disease in the scleroderma patients. Recently in June, FDA gave emergency use authorization for the treatment of COVID-19 in hospitalized adults and children. So it is only for the people who are hospitalized and with the severe infections and not for the outpatient setting. I'd like to touch a little bit about giant cell arthritis on polymyalgia rheumatica because we use the Actemra for those giant cell arthritis patients. We don't have much rheumatological emergency, but this is one of them. You don't want, because it can cause blindness. You don't want to miss that giant cell arthritis if you entertain the diagnosis for the people who usually present with a headache in the temple area, severe headache not improved with the Tylenol, acetaminophen, or anti-inflammatory medicine, severe headache, and people ages over 50 years. So and then if you entertain that giant cell arthritis diagnosis, you must start treating them with the prednisone, mainly like 1 milligram per kg. So if you miss that, there is a chance that they could go blind on that eye. It can also cause stroke and aortic dissection and rupture. I have seen one patient with that tongue necrosis and jaw claudications. And it's also caused that, dysphagias, pain in that jaw area, or when you chew, they can't chew. When they chew food, it's a lot of pain in the jaw area. So this is a study that got us Actemra approval, and they randomized 251 patients. One is for Actemra every week plus 26 weeks prednisone taper, or Actemra every 2 weeks and 26 weeks of prednisone taper, plus placebo. Placebo meaning, they are at least on there only for the prednisone, and 26 weeks versus 52 weeks. Primary endpoint was that patients who are in remissions, meaning no symptoms of flare-up, and normalized C-reactive protein, who have taper off the steroids in 52 weeks. Of course, the Actemra and both, with every week or every 2 weeks, they have a better outcome. That's why we got approval to treat giant cell arthritis with Actemra. This is a diagram showing that tocilizumab and sarilumab, the both are IL-6 inhibitor. They can bind soluble and membrane receptor. Sarilumab is like fully human antibody. And the tocilizumab is humanized and antibody. This medicine is approved to treat rheumatoid arthritis in 2017. We use every 2 weeks as sub-Q injections. So pretty much side effects are pretty much the same. Monitoring is pretty much the same as well. The next medicine is Janus kinase inhibitor. So when the cytokine like IL-6 bind the receptor, there's a cascade of chemical reaction happen and eventually lead to the activations of the transcription. Different kind of JAK inhibitor, 1, 2, 3, and TYK2. The Xeljanz, tofacitinib is blocking the 1 and the 3. it is the oral biologic. People love to take pills over the injection. So this is a very popular medicine among patients who does not like to take injectable medicine. Side effects can cause GI perforation, liver toxicity, and cholesterol abnormality, and low WBC. We do monitor cholesterol, ALT, and of course, patient has to have a negative TB skin test. Basically, we started the medicine, check the blood tests, of course, baseline, a month after starting the medicine, and every 3 months, as long as they take the medicine, you have to check cholesterol, CBC, LFT, and creatinine. Pregnancy and lactations is unknown, so we avoid those kind of medicines on people who wants to get pregnant or in the future. However, one good thing is Xeljanz is a short-acting medicine. So, if there is infections or if they want to get pregnant, we can stop the medicine and change to the different medicine, which will not affect the baby or pregnancy. It is also approved for the ulcerative colitis, and study have found that the tofacitinib can walk faster. So there's an improvement in the patients after 8 weeks even compared to the placebo. Another medicine, Janus kinase inhibitor, is baricitinib. It is easier to pronounce, Olumiant. It's an oral medicine approved to treat the rheumatoid arthritis. The side effects are very prominent is venous thrombosis. So we like to avoid the people who has a history of PE or DVD, if possible. The cholesterol test can be elevated as well. Monitoring pretty much the same. We don't use it for pregnancy in pregnant. We don't have a data on the pregnancy and the lactations. In cytokine storms inhibition of IL-6 signaling, there's no effect against sepsis syndrome. IL-6 is, we know that it's a predictor of the poor outcome in the COVID-19 patients. People who die had a higher IL-6 level than people who survive. And high level of IL-6 and D-dimer reflect the systemic inflammation and thrombotic condition. It's a predictor of the high mortality in the COVID-19 patients. Unfortunately, it's not improving the survival. It might improve that hospital stay here. I think that's where the money is, because here it is very expensive to stay at the hospital. That's probably the reason people use it. There's no improvement in the mortality. There's no proven benefit of TNF inhibition, even though TNF-alpha is elevated in patients with that in the acute inflammatory phase. And there's no data proving that it is working in cytokine storm. Any questions so far, or should I continue? It's been already 1 hour, right?
There are some questions in the chat box.
Okay, let me see.
First one is, are autoimmune diseases having more cytokine storms during COVID infection than normal people?
Having more during COVID infection? Not necessarily. No, we don't see that. We cannot say that where our patients have more, cytokine storm. Some even argue that because of the immunosuppressant medicine, they might not, trigger that, but, we don't have a proof that. More and more, we have a reporting system, so hopefully in the near future, we will see that what our patient population, when they have a COVID-19, we will see that. There's COVID generating inflammation cytokine storms. Yeah, there's no proven data of sulfasalazine. Sulfasalazine shortage is not because of using that COVID-19 using in COVID-19 because of the production. So some company don't produce sulfasalazine after during the COVID for some reason. This Plaquenil shortage, the same thing, they don't get the raw material, so the production is slowed down, and we also use it for the COVID-19 for Plaquenil at the beginning, but there's no proven benefit at this point. Do I think autoimmune cases or cases of sulfasalazine respiratory COVID vaccination as other normal people? Yes, sulfasalazine, I will talk about that, in the next vaccination topic. If patient is on Plaquenil or sulfasalazine, we don't need to make adjustment. They can have a vaccination and produce antibody. Under biologic immunosuppressant, please may I know about the biologic, how many type of immunosuppressant drugs we have. Yeah, so I have it in the next slides. Okay, so should I continue talking about it, or we have time ups and we have to, save it for the tomorrow?
Now slide below me. They let me know. Mama,
Manapan Dragaro, Nene Shirome, who joint present also differential diagnosis of joint, joint pain, no? So not many slides for that. So we can talk about that, what are the biologic immunosuppressant, what are the disease, traditional disease modifying agent tomorrow, together with the vaccination. Yeah.
ဟုတ်ကဲ့မှာအဲ့ဆိုတော့ဒီနေ့ကိုနည်းနည်းမေးခွန်းလေးတွေထပ်ရှိသေးရင်ဆရာတို့တွေကမေးချင်တာလေးတွေရှင် hand raise လုပ်ပြီးတော့မေးလို့ရပါတယ်မေးခွန်းလေးတွေနဲ့ပဲနည်းနည်းဆက်ပြီးတော့မေးခွန်းလေးတွေဖြည့်ပြီးတော့တင်လိုက်ပါမလားမ
Yeah, that's very yeah
ဟုတ်ကဲ့မမနေ့ပြန်မအချိန်ရှိတယ်ဒီနေ့သိကြသွားမှာဆိုလို့ပါ
ဟုတ်တယ် yeah
ဟုတ်ကဲ့မဟုတ်
ကျော်ဝင်းရှင်ပါအမတခုလောက်မေးလို့ရမလား
အေးကျော်ရှင်
အမတို့ကဒီ patient တွေ DMARC စီစထားပြီးသား patient တွေပေါ့နော် COVID ဖြစ်လို့ရှိရင်ဘယ်လို manage လုပ်လဲအဲ့ဒါလေးပြောပြပေးပါလားဟုတ်
မတို့တော့အကုန်
တွေရက်လာဘယ် condition မှာရက်လဲပေါ့နော်ဟုတ်
မတို့ကတော့အကုန်ရက်လိုက်တာပဲလေဘာလို့လဲဆိုတော့များသောအားဖြင့်ကိုသိတဲ့အချိန်ဆိုလို့ရှိရင်ကိုခေါ်ခံရတယ်ဆိုလို့ရှိရင်သူတို့ကစိတ်ယုံကနေခေါ်ကြတာများတာ哦ဆိုတော့အဲ့ချိန်ရောက်ပြီဆိုလို့ရှိရင်တော့စိုက်ကရက်လိုက်တယ်ဒီ outpatient mild to mild symptoms ဆိုတခါလေကြလို့ရှိရင်ကိုလည်းမသိလိုက်ဘူးပေါ့နော်မသိလိုက်လို့ရှင်တော့သူတို့တခါလေးဆက်တောက် Plaquenil ကိုဘာလို့ဆက်တောက်နေလို့ရှင်လဲဆက်တောက်မှာပေါ့ဒါပေမဲ့သူတို့ကို contact လုပ်လာတယ်သူတို့ symptoms တွေက very ဘယ်လိုခေါ်မလဲ they are sick usually they have a lot of symptoms like joint pains and they sleep a lot etc so they for those cases we ask them to stop the medicine. Are you doing the same thing or any, psycha? Do you hold Plaquenils or, psycha? Of course, we continue the prednisone. We can stop the prednisone if they are taking it for a long time.
Oh, ဒီနေ့ပဲအဲ့ဒါဟိုတခြား colleagues တွေလည်းမေးကြည့်နေရလေသူတို့လည်းအဲ့လိုများသောအားဖြင့်တော့ရက်တယ်ပေါ့နော်ဒါပေမဲ့တချို့ case တွေကတော့အကယ်၍ severe ဖြစ်တဲ့ဟိုdisease တွေဆိုလို့ရှိရင်တော့based on the case ပေါ့တင်
So there's a question. Baricitinib is having thromboembolism risk, then is it safe to use a COVID-19? That is a very good question. Yeah. Well, when you were hospitalized, I presume that, it's like it is approved for the hospitalized patient. So most likely they are on like anticoagulations of some sort. So I wouldn't, we can't say that it's not safe to use that COVID-19. We will have more and more data if it's just approved. So we don't know yet. COVID-19, it's a rapidly evolving. Every day is changing, and even though they are approved to treat at this point, it might be changing in the near future. What do you think, Joe Winston?
ဟုတ်thromboembolism risk ကတော့ပြောကြတာပဲအမပြောတဲ့အတိုင်းပါပဲဒီမှာအရေးကြီးတာဒီ infection ကို treat လုပ်ဖို့ကအရေးကြီးတယ်ဆိုတော့ risk နဲ့ benefit ကို balance လုပ်အောင်ပေါ့နော်နောက်ပြီးတော့ thromboembolism ကလည်းဒီ Xeljanz tofacitinib မှာလည်းရှိရပဲလေသူတို့ပြောတာဒါပေမဲ့တိတ်ကြီးတော့ဟို common ဖြစ်ပြီးတော့တွေ့ရတာတော့မရှိပါဘူးနော်အမတွေ့ဘူးဟုတ်
မတွေ့ဘူးဒါပေမဲ့ rheumatoid arthritis itself is a risk of thromboembolism ရှိတာပဲ whether they are on those medicine or not လေနော် so Thank you, Joe Winston, for the slides. That's very. She put a lot of time and energy to that. Ama just pick and choose and it's like present. So thank you for that.
Yeah, my input တွေလည်းပါပါတယ်
Any other questions? The questions are very good questions.
ဒီကုန်းနေတော့မှအခုတော့ chat box မှာတော့ထပ်တက်မလာတော့ဘူးဟုတ်ကဲ့ဒီဆရာဆရာမတို့ဓာတ်ရိုက်မေးလို့ရပါတယ်ခင်ဗျ chat box ကနေရိုက်ဖို့အဆင်မပြေမှာဆိုလို့ပါ
တုံးရပါကေကျုံဝင်ချင်မှာကျုံဝင်ရှင်နဲ့မဝင်းမသိန်းတော့ဟိုပါကျွန်တော်ဟို immunology အကြောင်းဒီထဲမှာနည်းနည်းပြောတော့ဒီ cytokine storm မရတဲ့လူနဲ့ cytokine storm မရတဲ့လူတွေရှိရပါလေ covid မှာနော်တချို့ကတော့ minor နဲ့ပဲပြီးသွားတယ်တချို့ကတော့ very severe နဲ့ပြီးသွားတယ်ဆိုတော့ a host factor ကများဟိုမတို့ဖတ်မိတဲ့ literature ထဲမှာကျုံဝင်ရှင်တို့ review လုပ်တဲ့ literature ထဲမှာ a host factor ပိုအရေးကြီးလဲ is there any research on host factors
Do you have any answer? I don't know much.
Yeah အဲ့ဒါတော့တေချာမသိဘူးလို့ထင်တာပဲပြန်တော့ဖတ်ကြည့်အောင်နော်တေချာပြောထားတာမရှိဘူးသူတို့ genetics တော်တော်များများဒီလို rheumatic disease တွေမှာဆိုလို့ရှင်လဲ multifactorial ပေါ့တင်မှာသူ genetic susceptibility ကြောင့်လည်းပါမယ်သူရဲ့ဟိုဘယ်လို immune response ကဘယ်လိုရှိလဲဆိုတော့ဒီဘယ်သူကဟိုဖြစ်တယ်ဆိုတော့အခုထိတော့အသေးစိတ်မတွေ့မိသေးဘူး
ဒီလိုမျိုးအကျူးမှာဖြစ်တဲ့ cytokine storms တွေနဲ့အဲ့လိုမျိုးပေါ့နော်ဒီ long term autoimmunity ကြောင့်ဖြစ်တဲ့ disease တွေနဲ့ pathophysiology genesis ကတော့နည်းနည်းကွာမယ်လို့ထင်တာပဲ right ဆိုတော့အဲ့ဒီဟာကိုဟိုဒီ research နည်းနည်းဟို data နည်းနည်းရှိလားအဲ့လိုမျိုးပေါ့နော်
You mean the autoimmune? Yeah, autoimmune or macrophage activation syndrome no, but အဲ့ဒါကြောင့်ဖြစ်တဲ့ဟာကိုပြောတာလား
autoimmune ကြတော့ they really develop over time right it's never really acute right so they do the immune mechanism there must be some differences in like acute setting like a COVID-19 cytokine that's just my common sense but I'm not really sure people have looked into these factors and how different in pathophysiological aspects of these like a very acute cytokine storm and the pathophysiology of the like a rheumatoid arthritis or other autoimmune diseases because I think there must be some critical differences underlying critical differences just a guess
Yeah, we don't really know that what exactly is triggering the autoimmune, it's like conditions as well. We just know that what happened in that, the joints, or like, inflammations, like what cytokines are causing it. We came really far, but still we don't know that some patients respond well to the TNF, some don't. And some are better with the IL-6 inhibitor or Xeljanz. So we even though we came a long way, we still don't know why people respond to that different medicine in different way. So yes, more research needed to be done. And we have a registry for the autoimmune patients who have COVID-19. So hopefully that those data will come out, in the future.
Thank you, Mama.
ဆရာတို့ဆရာမတို့မေးခွန်းလေးတွေရှိရင်မေးလို့ရပါတယ်ဆရာတို့ဆရာမတို့မရှိတော့ဘူးထင်တယ်အမဟိုမနက်ဖြန်ကြမှာပဲသူတို့မေးကြရှိနေဆက်ပြီးမေးလို့ရပါသေးတယ်အမမနက်ဖြန်လည်းအမရဲ့ session ကရှိသေးတာဆိုတော့လေအမဟုတ်ကဲ့
Yeah. Okay.
အော်
Yeah.
ဗာများဖြည့်ဆွဲပြီးတော့ထပ်ပြောခြင်းတွေထဲမှာဒီနေ့ session first day 1 session ပဲဟုတ်ကဲ့ပါ
Oh no. Thank you all for your attentions and participations, and we'll see you guys tomorrow.
ဟုတ်အမဟုတ်ဒီမှာ question လေးတစ်ခုကအခုမှရောက်လာတော့အမ
Oh, okay.
တချို့
Um,
ဆေးတွေက
mhm.
မတွေ့ရတယ်ထင်တယ်ဟုတ်ကဲ့အမ
Yeah. I don't know. It's like yeah, at Timra I look it up because hိုတလောတော့300လောက်တွေပါဖြစ်သွားတယ်ကြားတော့ဒီမှာတော့1စကို1 bio $500 something like that. I don't know about that, Sutrovimab medicines. Usually they are very expensive. Here, even patients, some patients, even though they have insurance, they can't afford to have those infusion, or like those medicine. I'll take a look at it and how expensive it is and let you know tomorrow. Okay.
ဟုတ်ကဲ့အမဟုတ်ကျေးဇူးအများကြီးတင်ပါတယ်ဟုတ်
Okay. Yeah.
ဆရာတို့ဆရာမတို့အားလုံးလည်းကျေးဇူးအများကြီးတင်ပါတယ်ကျွန်တော်တို့မနက်ဖြန်မနက်7:00နာရီမှာပြန်တွေ့ပါမယ်အမ women thing ရဲ့ rheumatology day 2 session ရှိပါတယ်ခင်ဗျဟုတ်ကျေးဇူးပါ
Okay. Thank you so much. See you tomorrow. Bye.
ကျေးဇူးတင်ပါတယ်အမ